Welcome back, everyone, to the deep dive.
Mm.
We're all plastic surgery residents here getting ready for the FRCS exam, right?
Mm.
And you also know that there's just so much to know.
It never ends, does it? But hey, that's what makes it fun. At least sometimes.
Today, we're going to really dive deep on a topic that's
Mm.
a must-know for the exam and actually, for our future practice, too.
Totally.
Tendon transfers.
Yeah.
We've got this whole chapter from, well, the recommended source,
Yeah.
and it's packed with info. But let's be honest, who's got time to read all of it?
Definitely not me.
So in this deep dive, we'll break it down to the bare essentials, the need-to-know stuff. Consider this like your cheat sheet for tendon transfers. Perfect for that last-minute cram session before the exam.
Love it.
And even better, once you get the concepts, you'll actually be able to use this knowledge in the OR.
100%. It's not just about passing the exam right, it's about becoming better surgeons. And understanding the ins and outs of tendon transfers, that's a huge step in that direction.
All right, so let's get started. First things first, back to basics. What exactly is a tendon transfer?
So basically, it's all about restoring function, not just movement. Like, imagine your hand as this intricate machine, right?
Yeah.
With all these moving parts working together. When a tendon's injured or a nerve gets damaged, a part of that machine just stops working.
Right.
A tendon transfer is kind of like finding a new cable, to power that part up again.
Okay.
We take a working muscle and tendon, what we call the donor, and we reroute it to the non-functional one, basically giving it a new power source.
So it's like rewiring the system, finding a new energy path to get that specific function back online.
Exactly. But just like any rewiring job, you need the right parts and the right conditions for everything to work smoothly.
Makes sense. And speaking of those right conditions, the chapter talks about a few must-haves before we even think about a tendon transfer. The first one is supple joints. Why is pre-surgery range of motion so important?
Well, think of it like this. A tendon transfer can't magically create more range of motion than the joint already has.
Right.
If the joint's stiff before surgery, it's going to be stiff after, even with a perfectly done transfer.
Yeah.
Addressing any contractures beforehand is key, like super important for a good outcome.
So it's not a fix for a stiff joint. The transfer tendon can only work within the limits of what the joint can already do.
That's it. You can't expect a brand new engine to make a car with a busted transmission go any faster. You got to fix the underlying problem first.
Okay, makes sense. Next up, stable soft tissue. No inflammation or instability allowed. Why is that so crucial for tendon healing?
Because a freshly transferred tendon is pretty delicate, right? It needs a healthy environment to heal properly.
Mhm.
Inflammation and instability, they can cause adhesions, which are basically like scar tissue that restricts movement.
Ah.
It's like, imagine trying to move a rope through a whole bunch of knots. It's just not going to work well.
So inflammation and instability make it a hostile environment for that healing tendon. They could even ruin the whole transfer.
Yeah, pretty much. We got to create those perfect conditions for that tendon to really thrive in its new spot.
Got it. So we got supple joints, stable soft tissues. Now for the main player, the donor tendon. And I'm guessing this isn't a one-size-fits-all situation, right?
Not at all. Picking the right donor is critical for success. It's not as simple as just grabbing any tendon that's available. There's specific criteria it needs to meet, and our chapter lays it all out for us.
Okay, let's break down those criteria. First up, expendable. What does that even mean in the world of tendon transfers?
It means we can sacrifice that donor tendon without causing a major functional loss somewhere else. It's like having a spare tire in your car. You don't want to be stuck on the side of the road if you get a flat tire. We have to make sure there are other muscles and tendons that can take over the donor's original job.
So redundancy is key. It's like having backup singers in case the lead vocalist loses their voice.
Exactly. Like, think about the tendons that control wrist extension. We've got a few of them, right?
Right.
We can choose one that's not absolutely essential and still have good wrist function. You wouldn't want to use the only wrist extensor the patient has.
Makes sense. Okay, next requirement. Single function. Why is that so important?
Because trying to make one transferred tendon do too many things is like asking one person to juggle 5 different jobs at once. They might be able to kind of do each task, but not as well as someone who's just focused on that one thing. It's better to focus on restoring one specific function really well than trying to fix multiple problems with a single transfer.
Okay, so quality over quantity. It's about making that transferred tendon a specialist, not a jack of all trades.
You got it.
The chapter also mentions adequate excursion. What does that even mean? And how does Table 71-1 help us figure out if a donor is a good fit?
So excursion is basically how far a tendon can move. Think about trying to replace a long jump rope with a short one you wouldn't get very far, right? Same goes for tendon transfers. The new tendon needs enough reach to match the original tendon's movement.
Okay.
Table 7:1 shows us the relative reach or excursion of different muscle tendon units. That helps us pick a donor that's long enough to actually do the job.
So it's like a compatibility check, making
Yeah.
sure the donor tendon can handle the range of motion we need.
Yeah, exactly. And the table even talks about this 3-5-7 rule to estimate tendon length based on where we're attaching it. It's a handy little trick to quickly see if a donor's long enough.
Nice. So we don't end up with a tendon that's too short for its new job.
Exactly.
Speaking of the right tool for the job, adequate power is another big factor. Table 7:1-2 comes in handy here. It shows the relative strength of different muscle tendon units.
Yeah, we got to make sure the donor is strong enough to do what we're asking it to do. You wouldn't want to ask a tiny kid to lift a huge weight,
Right.
right?
Definitely not. So we're matching the donor's strength to the demands of the function we want to get back.
Right on. We need a donor that's up for the challenge.
Next up is appropriate vector. What's vector in this context, and why does it matter?
Vector is just the direction the tendon pulls. Like, imagine trying to open a door by pulling it sideways instead of pushing it forward. It's not going to work.
Right.
The new tendon needs to pull in the same direction as the one it's replacing to create that movement we want.
So we need to line up the donor tendon's pull with how the hand naturally moves.
Precisely. We want the new tendon to work with the hand, not against it.
Makes sense. And finally, we have synergy. Sounds like a teamwork thing.
Totally. Synergy is about working with the body's natural movements. Certain muscle groups just work together for certain actions, you know?
Uh-huh.
It's way easier to retrain a muscle if we keep the transfer within these natural groups. Like, you wouldn't put a basketball player in as the goalie in a soccer game, right?
Right. You want everyone to play to their strengths. And the source actually mentions two main synergistic groups.
Yeah, one's for supination, wrist flexion, finger extension, and adduction. The other's for pronation, wrist extension, finger flexion, and abduction. Ideally, we keep our transfers within those groups.
So respect the hand's natural flow for better retraining.
That's the idea. Work with the hand's design, not against it.
Okay, so before we jump into specific cases, the chapter reminds us that tendon transfers aren't always the first line of treatment.
Yeah, good point. We should always try to address the root cause if we can. Like with nerve injuries, direct nerve repair or grafting might be a better choice. And for tendon injuries, primary repair or grafting is usually our go-to.
Right, those approaches have their advantages. No tendon junctions to worry about, and the original muscles are already the right strength and pull in the right direction.
Exactly. But sometimes those options just aren't possible. The nerve might be too damaged, the tendon might be beyond repair, or maybe there's a lot of muscle involvement too. That's when tendon transfers become a really valuable tool for us.
So there are backup plan when the primary approach isn't going to cut it. The chapter also mentions splinting and something called internal splinting. What's that about?
Splinting, both the static and dynamic kind, can help support a joint's or even encourage movement. Internal splinting is basically procedures like arthrodesis, which is joint fusion, and tenodesis, which is tendon fixation. They create a fixed point of stability inside the hand.
Oh, okay. So these might be used in situations where a tendon transfer isn't the best fit, or maybe even alongside a transfer.
You got it. It all depends on the patient and their specific needs. It's about finding the best way to restore function, taking everything into account.
All right, so we've covered the basics of tendon transfers, the must-haves for success, and some alternative approaches. Now, let's get into the nitty-gritty. When are tendon transfers the go-to solution?
All right, let's do it. And as we mentioned earlier, nerve injury is a classic scenario where tendon transfers really shine.
Right, makes sense. If a nerve is damaged and can't be fixed directly, you've lost the signal that tells the muscle to contract. A tendon transfer can bypass that damaged nerve and get things working again.
Exactly. And the chapter actually talks about things that make us decide whether to do the transfer right away or wait. Like if there's a ton of muscle damage or the nerve injury is way up high, an immediate transfer might be the better option. But other times we might wait and see if the nerve recovers on its own, especially if the injury is not too bad and there's a good chance for the nerve to regenerate.
So it's a strategic decision based on what kind of nerve injury we're dealing with and how severe it is.
Exactly. We have to be smart about it.
The chapter also lists tendon injury as a reason for a transfer. So when primary repair or grafting is not an option, a transfer can step in and restore function.
That's right.
And sometimes we see combo injuries, affecting both tendon and nerve, or maybe there's really bad muscle damage. In those situations, tendon transfers can be lifesavers.
For sure.
What about spasticity? How can tendon transfers help in those situations?
Spasticity, which we often see in conditions like cerebral palsy, can cause muscle imbalances and those contractures we were talking about. Tendon transfers can help restore balance and improve function, though the chapter does say that outcomes are a bit less predictable in these cases.
Right. The chapter mentions specific transfers that are often used for spasticity, like transferring the FCU to the ECRB or the ECU to the ECRB to improve wrist and finger extension.
Yeah, those are good examples. They help counteract those overactive flexor muscles and give the patient a better chance of extending their wrist and fingers.
And finally, the chapter mentions medical diseases as a potential reason for a tendon transfer. What's an example of that?
Rheumatoid arthritis is a classic one. It can cause so much inflammation that it weakens the tendons, even leading to rupture. In those cases, a tendon transfer can be used to get that function back in the affected finger.
So we've covered a lot here. Situations where tendon transfers are the go-to move, but it's just as important to know when they're not a good idea. Let's talk contraindications next.
Yeah, knowing when not to do a tendon transfer is just as important as knowing when to do one. So let's get into those contraindications. First off, stiff or contracted joints. We touched on this a bit earlier, but why is it such a big deal breaker?
Because a tendon transfer can't magically create more range of motion than the joint had before surgery, right?
Yeah.
It's not a miracle worker.
Exactly. If the joint's stiff, the transfer just won't be effective. It could even make things worse. Remember that car analogy? Got to fix the flat tire before you can expect the car to run right. We have to address any contractures first.
So supple joints are non-negotiable. What about inflammation in the surgical area? If things are still hot and bothered, is that a problem?
Absolutely. Inflammation is a big no-no. It leads to those adhesions, those pesky bands of scar tissue that can really mess things up. They restrict tendon movement and basically compromise the whole transfer.
So we need to create a peaceful, calm environment for that transferred tendon to really settle in and do its job.
Precisely. Minimize inflammation and give that tendon the best chance of success. And of course, if we don't have a suitable donor tendon, well, that's game over.
Yeah, that's a pretty obvious one. Can't do a tendon transfer without a good donor. And even if we do find one, it has to tick all those boxes we talked about earlier. Expendable, single function, enough excursion, power, the right vector, and synergy.
You got it. Choosing the right donor is a huge part of planning these surgeries. The chapter also talks about identifying a specific functional deficit. What does that mean exactly?
It means we need to be crystal clear about what function we're aiming to restore. Just having limited motion in a joint isn't enough to justify a tendon transfer. There needs to be a specific task, something the patient can't do because of that limited motion that we're targeting.
Right, exactly. We need to pinpoint what's actually impacting the patient's life, what they're struggling with. Like, if someone can't make a fist because of a tendon injury, that's a specific deficit a tendon transfer might be able to fix.
Okay, that makes sense. And the patient's motivation and reliability also play a big role, right?
Huge role. Tendon transfers require a lot of work after surgery, tons of therapy and retraining. The patient has to be totally on board and committed to the rehab process if we want the transfer to be successful. It's like training for a marathon. You need that drive and dedication to reach the finish line.
So a motivated and compliant patient is a must-have. No slacking allowed. What about uncontrolled systemic diseases? Are those a deal breaker?
They definitely need to be addressed before we even think about a tendon transfer. Like, if someone has uncontrolled rheumatoid arthritis, we have to get that disease stabilized before we can even consider surgery.
It's like building a house on a shaky foundation. You need a solid base for the structure to stand strong. The chapter also mentions athetoid movement as a contraindication. What is that, and why does it make tendon transfers so tricky?
Athetoid movement is basically involuntary muscle activity that's kind of unpredictable. It can be anything from really stiff to really floppy, and it's hard to tell what it's going to do next. It's like trying to hit a moving target. Makes it tough to predict how a tendon transfer will turn out because the transferred muscle might not behave the way we want it to.
So it throws a wrench into the whole precision thing we need for a successful transfer.
Yeah, pretty much. And lastly, there's advanced age. It's listed as a relative contraindication. Any idea why?
Probably because retraining muscles and tendons is harder in older patients. Their bodies might not bounce back as easily.
You got it. Age isn't necessarily a hard stop, but it's true that retraining can be more demanding as we get older. Our bodies just don't heal and adapt as quickly.
So it's a factor to consider, but not always a deal breaker.
Okay, so we've covered those key contraindications for tendon transfers. Now, before we move on to specific transfer techniques, let's touch on the preoperative evaluation. What are the essentials we need to cover? What do we absolutely need to know before we go in?
A super thorough history is crucial. We need to know when the injury happened, any treatments they've had before, their specific functional limitations, and their overall medical history, including any chronic conditions.
And of course, a detailed physical exam is a must. Got to see what we're working with.
For sure. We need to assess their nerve and tendon function, how much range of motion they have, how their scars are healing, and what potential donor tendons we might be able to use. The chapter even mentions checking for the palmaris longus as an example.
Oh, right. The palmaris longus, that tendon in the forearm that some people just don't have. It's a popular donor because it's pretty expendable, but we got to make sure it's actually there before we plan on using it.
Exactly. No point in planning a surgery around a tendon that's missing in action. And finally, we need to gauge the patient's motivation and reliability. Make sure they're ready to put in the work for rehab.
Right. We need to be sure they understand what's involved after surgery and that they're committed to the whole rehabilitation process.
So a thorough pre-op evaluation is like laying the groundwork for a successful outcome, getting all our ducks in a row.
You got it. It's all about gathering the info we need to make smart decisions and plan the best treatment for each patient. Now let's get down to the details. Let's talk about specific functional deficits and explore the different ways we can use tendon transfers to address them.
Okay, let's dive into the how-to of restoring function with tendon transfers. We'll focus on those three main nerve territories: median, ulnar, and radial.
Sounds good. Let's start with the median nerve.
All right, what are some of the common problems we see with median nerve injuries? What functions tend to go offline?
One of the classic ones is loss of thumb opposition. That's the ability to bring your thumb across your palm to touch your fingertips. It's super important for a ton of things, from gripping objects to buttoning a shirt.
Right, it's what makes our hands so good at doing all those intricate tasks.
Yeah.
So what causes this loss of opposition? Is it always a median nerve issue?
It can be caused by a median nerve injury, anywhere along the nerve, or even damage to the C8-T1 nerve roots. Basically, the muscles that do that thumb opposition thing stop getting the signals they need to work.
So the communication lines are down, and those muscles are essentially paralyzed. What are our options for getting that thumb opposition back? Can tendon transfers help?
Absolutely. There are a few techniques, but they all involve attaching a donor tendon to the insertion point of the abductor pollicis brevis muscle, the main muscle responsible for thumb opposition. It's over on the thumb side of the hand near the base of the thumb. We're essentially rerouting a new cable to power up that muscle.
So we're hijacking that insertion point and giving it a new power source, a new lifeline. What tendons do we usually use for this? Are there any go-to donors?
One option is the extensor indicis proprius, or EIP. It's a tendon that extends the index finger, and it gets its signals from the radial nerve. That means it's usually available for transfer when there's a median nerve injury.
The chapter says that the EIP is tunneled under the skin, around the ulnar side of the hand, and across the palm to reach that insertion point on the thumb. Seems like a bit of a journey for that tendon.
It is. It's a bit of a roundabout route, but it's a reliable technique. Another option is the flexor digitorum superficialis tendon to the ring finger. We loop that one around the flexor carpi ulnaris tendon as a pulley to change its direction of pull.
But that one wouldn't work if there's a high median nerve injury, right? Because the flexor digitorum profundus to the ring finger would also be affected.
You're absolutely right. We have to pay attention to the level of the nerve injury when we're picking a donor tendon. Always think about which muscles are out of commission and which ones are still working.
Good point. The chapter also mentions the palmaris longus tendon. That's the one that some people don't even have, right?
Yep, about 14% of people are missing it, but when it's there, it can be a good choice because it doesn't have a primary function, so we're not really losing anything by using it. In this technique, the palmaris longus and some of the palmar fascia are passed under the origin of the abductor pollicis brevis as a pulley. It's called the Kamitz technique.
The chapter says the Kamitz technique doesn't sacrifice any function, but the movement might be a bit weak.
Yeah, it's not the strongest option, but it's a good choice when preserving function elsewhere is a priority. Another option is the abductor digiti minimi, or ADM, a muscle on the little finger side of the hand. This is the basis of the Huber technique.
So with the Huber technique, we're basically borrowing a muscle from the finky side to power up thumb opposition.
Exactly. We detach the ADM insertion, flip it 180 degrees, and then attach it to the thumb. It's a good match for power, and it adds some bulk to the thenar eminence, that fleshy area at the base of the thumb.
But the chapter says it mostly gives us flexion and pronation, not much abduction, so maybe not the best choice if we want to get full opposition back.
That's a good point. We have to consider the specifics of each technique when choosing the best option for the patient. What aspects of opposition are we trying to restore? Which technique will help us achieve that?
What about other tendons, like the ECRL, ECU, or EDQ? The source mentions those as possibilities too.
We can use those as well. The routing is similar to the EIP, but we might need a tendon graft to make it long enough. Tendon grafts are like extensions, basically. They let us bridge the gap when a donor tendon can't quite reach its new insertion point.
Like an extension cord for tendons. I like it. Okay, so we've covered a lot on restoring thumb opposition, a key function of the median nerve.
Yeah.
What are some other issues we might see with median nerve injuries? What else goes wrong when that nerve's out of commission?
Another common one is loss of thumb flexion, mainly because the flexor pollicis longus, or FPL, is paralyzed. This muscle is what lets you bend the tip of your thumb, which is crucial for pinch grip and a ton of other hand movements.
Yeah, this can also be caused by a high median nerve injury or CAT1 nerve root damage.
Right? Exactly. It's also the most common tendon to rupture in rheumatoid arthritis because it rubs against the scaphoid bone in the wrist. So it's a problem we see in a lot of different situations.
So how do we get that thumb flexion back? What are our tendon transfer options?
We typically weave the donor tendon into the distal part of the FPL tendon. Some commonly used donors include the brachioradialis, the extensor carpi radialis longus, ECRL, and the flexor digitorum superficialis to the ring finger.
The chapter mentions that those tendons are usually available because they get their signals from the radial or ulnar nerve, meaning they're spared in median nerve injuries. And they have the added bonus of minimal donor site deficit, so we're not creating new problems by taking them.
Exactly. It's always a balancing act. Restore function without causing a new deficit somewhere else. That's the goal.
The source also mentions these end-to-side transfers. What are those all about?
That's a technique we use when there's a chance the original nerve might recover. Instead of completely detaching the donor tendon, we attach it to the side of the recipient tendon. This way, the transfer tendon can help out and provide function, but it still allows the original tendon a chance to get back online if the nerve heals.
So it's like a temporary support system, a helping hand, until the original tendon can pull its weight again.
Exactly. The source specifically mentions that we often use the FDS for this type of transfer in cases of rheumatoid arthritis where there's a rupture.
Yeah, so another tool in the toolbox. And there's one more median nerve deficit we need to cover. Loss of index finger, DIP joint flexion.
Right. This is usually because of paralysis of the flexor digitorum profundus to the index finger, typically from a high median nerve injury or C8T1 root damage. Same culprits as the other two deficits we talked about.
And are the donor tendon options the same too?
Yep, same ones. Brachioradialis, ECRL, or FDS to the ring finger. And again, we can do an end-to-side transfer if there's a chance the nerve might recover.
So we've covered the main median nerve deficits and how we can use tendon transfers to restore function. Now let's move on to the ulnar nerve. What are some of the challenges we face when that nerve's injured?
Ulnar nerve injuries can cause a whole bunch of problems, but one of the biggest is loss of thumb adduction, which is really important for what we call key pinch.
Key pinch, right? That's how we hold a key, a pen, a credit card. Super important for everyday stuff.
Exactly. It involves the adductor pollicis muscle and the first dorsal interosseous muscle, both of which get their signals from the ulnar nerve. When that nerve's injured, those muscles get weak or paralyzed, making that key pinch grip really difficult or even impossible.
So what are our tendon transfer options for fixing that? Can we reroute a tendon to take over that job?
The goal is to attach a donor tendon to the ulnar base of the thumb proximal phalanx, which is the bone at the base of the thumb. This gives us that pull we need to adduct the thumb.
And what are some of the tendons we can use for that?
The ECRB and the brachioradialis are good options. They have decent power and there's minimal donor site deficit, which is always a plus.
The chapter mentions that those tendons have to be passed between the index and middle finger metacarpals into the palm, and then around the index finger metacarpal as a pulley to get to their new insertion point. Sounds complicated.
It is. And often we'll need a tendon graft to make them long enough. But it's a solid technique that can effectively restore thumb adduction.
What about using the FDS to the long or ring finger? The source mentions that as a possibility.
We can do that, but it's not ideal. It's retrieved in the palm and passed deep to the flexor tendons to get to the thumb. But it doesn't have much power, and the direction of pull isn't great, so it might not be as effective as the ECRB or the brachioradialis.
And again, we need to remember that the FDS to the ring finger wouldn't be available if there's a high ulnar nerve injury, because the FDP to the ring finger would also be affected.
Right, exactly. Always got to consider the level of the nerve injury when we're choosing a donor tendon. It's like a puzzle, figuring out which pieces we have and how to use them to fill in the gaps.
Okay, so we've tackled thumb adduction. What about those other ulnar nerve problems? What else do we need to worry about?
Another common one is loss of ring and small finger DIP joint flexion. That's caused by paralysis of the flexor digitorum profundus tendons to those fingers.
And we typically see that with high ulnar nerve injuries or C8T1 root damage, right?
That's right. One way to fix that is to suture the FDP tendons of the ring and small fingers to the FDP tendon of the long finger. This basically lets the long finger FDP power both the ring and small finger DIP joints.
Smart. But the chapter mentions that this could make clawing worse, which is another common problem with ulnar nerve injuries. That's where the fingers get that clawed look with the MP joints hyperextended and the PIP and DIP joints flexed.
Yeah, you're right. Strengthening DIP joint flexion can actually make the muscle imbalance that causes clawing even worse. It's like adding more weight to one side of a seesaw throws the whole thing off balance.
So fixing clawing requires a different strategy, one that restores balance to the whole system.
Exactly. We need to restore balance to the MP joint flexors, specifically the lumbricals and interosseous muscles. Those are the muscles that flex the MP joints, and when they're paralyzed, the extensor muscles take over, causing that hyperextension deformity.
So we need to find a way to give those MP joint flexors some power back, like a jump start.
Exactly. There are a few ways to do that, and the technique we choose often depends on whether the PIP joint capsule and extensor mechanism are normal or not. The chapter mentions the Bouvier test, which helps us figure that out.
The Bouvier test checks if we can bend the PIP joint passively when the MP joint is straight. If we can, it means the PIP joint capsule and extensor mechanism are okay.
Right. A positive Bouvier test gives us more options for fixing the clawing. The general idea is to pass a donor tendon along the path of the lumbrical muscle under the transverse metacarpal ligament and then attach it to one of a few possible insertion points.
So we're basically mimicking what the lumbrical muscle does, but using a donor tendon instead.
Precisely. And the chapter mentions 3 common insertion points: the lateral band, the proximal phalanx, or a loop around the A1 or A2 pulley. Each one has its pros and cons.
The lateral band is supposed to be the most anatomically correct option, but it might give too much power to the extensor mechanism. The proximal phalanx insertion avoids that problem, but it might not be as effective. And the loop around the pulley technique is kind of in between.
Right. Picking the best insertion point depends on the patient and how bad their clawing is. It's about finding that sweet spot between power and control.
Now, what about the donor tendons we can use for this? The chapter mentions the long finger FDS as one option. That's the basis of the modified styles bundle procedure, right?
Right.
We divide the FDS tendon distally, split it into 4 slips, and use those slips to reconstruct each lumbrical.
You got it. But the chapter points out a couple of downsides to this technique. It weakens grip strength, and it can lead to PIP joint hyperextension because we're basically taking away the PIP joint flexor. Kind of a robbing Peter to pay Paul situation.
Yeah, so there's a trade-off. We're gaining function in one area, but potentially losing it in another.
Exactly. We have to carefully weigh the pros and cons. The good news is there are other options that might help us avoid those problems. The source mentions using the FCR, ECRL, ECRB, or even the brachioradialis. We typically weave a tendon graft into the donor tendon and split it into 4 slips, just like with the FDS. These options have the advantage of improving grip strength and reducing the risk of PIP joint hyperextension.
So more choices to find the best fit for each patient.
Exactly. It's all about tailoring the approach to get the best possible outcome.
Wow, there's a lot to think about when we're dealing with clawing. It's amazing how many techniques and donor tendon options there are.
It really is. It shows how important it is to plan these surgeries carefully and really understand the nuances of each technique. We have to be like skilled architects, designing and building a solution that fits the specific needs of each structure.
All right, so we've covered the main ulnar nerve deficits and their tendon transfer solutions. Let's move on to the radial nerve. What happens when that nerve's out of commission?
Radial nerve injuries can cause all sorts of problems, but one of the most common is loss of wrist extension.
Right, wrist extension. We need that for so many things,
Mhm.
like lifting stuff, opening doors, even stabilizing the wrist when we're doing fine motor tasks like writing. What muscles are responsible for that?
The three main wrist extensors are the extensor carpi radialis longus, ECRL, extensor carpi radialis brevis, ECRB, and extensor carpi ulnaris, ECU.
And a radial nerve injury can knock out all three of those.
Yep, it can. The ECRL is usually lost with a high radial nerve palsy or damage to the C6-7 nerve roots. The ECRB and ECU can be affected by a radial nerve injury anywhere along the nerve, or by C6-7 root damage.
So if someone loses wrist extension, what can we do? Are tendon transfers an option?
We usually focus on reconstructing the ECRB because it's the strongest of the wrist extensors. The ECRL and ECU are usually not reconstructed unless there's a specific reason to do so.
So we prioritize getting the most important muscle back online. What donor tendons can we use for that?
The pronator teres is a common choice. It's a muscle in the forearm that turns the palm downward, called pronation. We detach the pronator teres at its insertion, route it under the skin, and then attach it to the ECRB.
So we're turning a pronator into a wrist extensor. Pretty cool.
Right. And we can do an end-to-side transfer if we think the radial nerve might recover, or an end-to-end transfer if recovery is unlikely. This gives us some flexibility depending on the prognosis. We can even use this transfer in a temporary fix while we wait for the radial nerve to hopefully heal. It acts as a sort of internal splint, keeping the wrist from drooping.
That's smart. Provides support, but still leaves the door open for natural recovery. Besides wrist extension, what other radial nerve deficits might we need to fix with tendon transfers?
Loss of finger MP joint extension is another common one. That's because of paralysis of the extensor digitorum communis, or EDC, which is the muscle that straightens the fingers at the MP joints.
And that can happen with a radial nerve injury anywhere along the nerve, or C7 root damage, right?
Yes, exactly. It can also happen in rheumatoid arthritis, where the EDC tendons can rupture from rubbing against the ulnar head, a bony bump at the wrist.
The chapter mentions doing a dorsal tenosynovectomy, which is removing the inflamed sheath around the tendons,
Yeah.
and maybe even taking out a piece of the distal ulna.
Right. Those procedures can help reduce inflammation and prevent further tendon damage. And if the MP joints have arthritis, we might need to do an arthroplasty to get the joint working properly again. It's all about addressing everything that's contributing to the problem to get the best result from the tendon transfer.
So if we're dealing with EDC paralysis, how do we get those fingers extending again?
We usually divide the EDC tendons at their musculotendinous junction and weave them into a donor tendon.
And what donor tendons can we use for that?
The flexor carpi ulnaris, or FCU, is a common choice. We route it around the ulnar side of the wrist, under the skin, and attach it to the EDC tendons. The flexor carpi radialis, or FCR, can also be used. It's routed around the radial side of the wrist.
So we're basically using a wrist flexor to power finger extension. That's pretty wild.
It is. And the source also mentions using the flexor digitorum superficialis of the long finger as a donor, especially in cases of rheumatoid arthritis where there are multiple tendon ruptures.
Interesting. How does that one work?
We divide the FDS between the A1 and A2 pulleys, those fibrous bands that hold the tendon close to the finger bones, and then route it around the wrist or through the interosseous membrane, which is that tough sheet of tissue between the radius and ulna bones in the forearm.
Okay, so we've covered wrist extension and finger MP joint extension. What's the last radial nerve deficit we need to talk about?
Loss of thumb extension and abduction. That happens because of paralysis of the extensor pollicis longus, EPL, extensor pollicis brevis, EPB, and abductor pollicis longus, APL muscles.
And that can be caused by a radial nerve injury anywhere along the nerve or C7-8 root damage.
Exactly. And EPL rupture is common in rheumatoid arthritis too.
So how do we restore thumb extension and abduction? More tendon transfers.
There are a few possibilities depending on which muscles are involved and what we want to achieve. One option is transferring the palmaris longus to the EPL, but we got to remember that not everyone has a palmaris longus.
Right, it's missing in a good chunk of the population. But when it is there, it can be a good option for restoring thumb extension.
Right.
How does that transfer work?
We divide the palmaris longus distally and the EPL at its musculotendinous junction. Then we move the EPL radially to Lister's tubercle, a bony bump on the radius, and direct it volarly, which means toward the palm.
So we're basically rerouting the EPL and giving it a new power source, the palmaris longus.
Exactly. The chapter mentions that this transfer is often combined with the FCU or FCR to EDC transfer that we talked about earlier.
Makes sense. A two-for-one approach to address multiple deficits at the same time.
Right. And if the palmaris longus isn't there, we have other options. The source mentions using the FDS of the ring finger to power the EPL.
So we're borrowing power from the ring finger to get the thumb extending again.
Yep. We divide the FDS between the A1 and A2 pulleys and route it around the wrist or through the interosseous membrane. And just like the palmaris longus transfer, it's often combined with the FDS to EDC transfer. So we're adjusting both finger and thumb extension using a single donor.
So two options for the EPL.
Yeah.
What about the EPB and APL?
For those, we can use the FCR. This transfer gives us independent radial abduction of the thumb, which is important for a lot of things. It's often combined with other transfers like the FDS to EDC and FDS to EPL.
Another multi-pronged approach, using one donor to tackle multiple problems.
Exactly. It's all about finding the right solution for each patient's specific needs.
And the last option mentioned is using the EIP to power the EPL, especially for EPL ruptures caused by rheumatoid arthritis.
Right. And in those cases, it's important to remove any bony bits that might be causing the tendon to rub and rupture.
So we're not just transferring a tendon, we're also fixing the underlying problem that caused the rupture. That's great. We've covered a ton of ground on specific functional deficits and the tendon transfer options for addressing them. It's amazing how many techniques there are and how we can combine them to tackle these complex problems.
It really is. Tendon transfers are a really versatile tool in our reconstructive toolbox. But we can't forget that surgery is only one part of the equation. Post-operative care is absolutely critical if we want to get good results.
Yeah, absolutely. We've talked about what tendon transfers are and when we do them, but now let's get into the aftercare. What happens once the surgery's done?
Post-op care is super important for a successful tendon transfer. It's where we as surgeons hand the reins over to the patient and their therapists. It's a team effort to get that transferred tendon working the way it should.
Okay, so walk us through the typical timeline. What happens right after surgery? What's the immediate plan?
Well, that transferred tendon needs protection right away. We're talking a big, bulky splint to keep the tendon at a length where there's no tension on the repair. It's like a cast for a broken bone. Got to immobilize the area to let it heal properly.
So we're preventing the tendon from pulling apart before it's had a chance to really heal in its new spot.
Yeah.
How long does that immobilization last?
Usually about a week or two. During that time, we'll check the incisions, make sure everything's healing okay, and probably switch out the splint for a more comfortable one.
And then things start moving, literally.
Yeah, around the 4-week mark, we start introducing some gentle, active range of motion exercises for the joints. This is where a thermoplastic splint, which we can mold to fit the patient's hand, is really helpful. It gives support, but still allows for some controlled movement.
It's a gradual process. We're not throwing them to a full-on workout right away.
No way. We got to find that balance between protecting the healing tendon and preventing stiffness. Too much movement too early could damage the repair, but not enough movement can lead to adhesions and those joint contractures.
It's a fine line to walk. When does the real muscle retraining start? When do we start teaching those muscles their new jobs?
Around week 6 after surgery, this is when we really focus on activating that transferred muscle tendon unit, getting it to fire correctly in its new role. Like teaching an old dog new tricks, the brain has to rewire itself to control the transferred muscle differently.
So it takes a lot of patience and practice from the patient. They're basically learning how to use their hand all over again.
Exactly. It takes time and dedication. No shortcuts here.
Okay, so gentle movement at 4 weeks, muscle retraining at 6 weeks. When do we add strengthening exercises? When can they start pushing those muscles a bit more?
Around 8 weeks post-op. And at this point, we can start weaning them off the splint too. The goal is to gradually build up their strength and endurance so they can get back to full function.
Like slowly increasing the weight a lifter can handle. Start light and gradually increase the load as the muscle gets stronger.
Good analogy. We got to challenge the transfer tendon without overdoing it.
Makes sense. So when can patients expect to get back to their normal activities? Back to their everyday life?
Usually by about 12 weeks after surgery. Of course, it varies depending on the patient, how complex the transfer was, and how committed they are to rehab. But generally, around 3 months.
Okay, so it's a journey. But with the right care and effort, patients can get great results. But as with any surgery, there are risks. What are some of the complications we need to be aware of?
One of the most common ones is tendon adhesions. Those are bands of scar tissue that can form between the tendon and the surrounding tissues. They can really restrict movement, making it hard for the tendon to glide smoothly, and that can limit range of motion and impact function.
The chapter says adhesions are more likely to happen if the tendons pass through an area that's inflamed. So keeping inflammation down during surgery is super important.
Absolutely. That's why we really emphasize meticulous technique and being gentle with the tissues during surgery. And if adhesions do develop, aggressive hand therapy can often break them up and get things moving again.
What about tenolysis? The source mentions that as a possibility too.
Tenolysis is a surgery to release those adhesions. We usually do it once the initial inflammation has settled down and the tissues have had time to heal.
So it's a last resort if hand therapy doesn't do the trick.
Yeah, we always want to avoid more surgery, if possible, but sometimes it's the best way to get a good outcome.
Another complication is transfer rupture. What causes that? Why would a transfer tendon just snap?
Rupture can happen if there's too much tension on the tendon or if it's not properly immobilized. It's like snapping a rubber band. Pull it too tight or don't support it enough and it breaks.
So we have to be really careful to protect that tendon during healing
Yeah.
and avoid any forceful movements that could put too much stress on it.
Exactly. And if a rupture does happen, we need to get them back into surgery right away to fix it and try to save the transfer.
Okay, and the last complication mentioned is transfer weakness. What causes that? Why might a transfer tendon not be strong enough?
A few reasons. Maybe the donor tendon wasn't a good match for the recipient in terms of power, or maybe the donor muscle itself was already weak or damaged. Like trying to tow a huge truck with a little compact car, the car just doesn't have the muscle to do it.
So choosing the right donor is crucial. Got to make sure it's up to the task.
Absolutely. Another possibility is that the tension on the transfer tendon wasn't set correctly during surgery, or the moment arm's too short.
The moment arm. That's basically the lever arm of the tendon. If it's too short, the tendon won't have enough leverage to create a strong contraction.
Right, like trying to open a door by pushing right next to the hinges, you need that leverage to generate enough force. Luckily, we can sometimes fix transfer weakness with surgery, either by adjusting the tension or lengthening that moment arm.
So even if complications do pop up, there are often ways to manage them and still get a good result. It's not always a lost cause.
Definitely not. We just have to stay on top of things and address any problems quickly to get the best outcome for the patient.
This has been a fantastic deep dive into tendon transfers. We've gone through the whole thing, from the basics to the indications, contraindications, surgical techniques, post-op care, and even potential complications.
Hopefully this gives you a good understanding of this essential part of hand and upper extremity reconstruction. It's something you'll definitely see on your FRCS exam, and it's a skill that will be super valuable throughout your career as a plastic surgeon.
Absolutely. This deep dive has given us the knowledge we need to not only rock the exam, but also make good decisions and get the best possible results for our patients.
Remember, successful tendon transfers depend on choosing the right patient, doing the surgery carefully, and having a dedicated rehab plan. It's a team effort, the surgeon, the patient, and the therapist all working together.
And let's not forget that surgery is always evolving. There's always more to learn and new techniques to discover. So stay curious and keep pushing the limits of what we can do.
Well said. Couldn't have said it better myself.
Thanks for joining us on this deep dive into tendon transfers. We'll see you next time on The Deep Dive.